Hi everybody, I'm Dr. Zainu Shams. I will be discussing about my experience in FRCS Glasgow ophthalmology clinical session in this video. So this will be a continuation of my previous video in which I have discussed about my Viva session. As I have told in the previous video, you will get 1 day break between your Viva and clinicals. It is very important to utilize this day wisely by brushing up your clinical demonstration skills. Don't attempt to read extensive theory on this day. Keep all your instruments cleaned and charged. For the clinical exam, you will have 4 stations, 2 examiners in each station. You have 12 minutes in each station and you should see 2 to 3 cases per station, which means you will get maximum of 6 minutes per case. You should use alcohol hand rub before attending every case. The exam center will provide you with all the necessary instruments, yet it is always better to use your own instrument. As the patients have given pre-consent, you don't have to take consent before examination unless you are asked to do so. Nevertheless, always inform the patient before proceeding to examinations like lid eversion or palpation of an acutely inflamed swelling. Exam center may be having different type of machinery than your practicing hospital. So always feel free to ask for help if you're struggling to adjust the height of the slit lamp or to find the switch of the slit lamp. Remember, you will get only a maximum of 6 minutes per case. Always examine in the systematic manner, but due to time constraints, explain only the relevant or positive findings. My first station was anterior segment. I was asked to examine the right eye of the first patient. I asked the patient to sit and keep the chin over the chin rest. I adjusted the height of the chin rest, quickly examined the brows and the lips. Conjunctiva appeared normal in the prima facie evaluation. I elevated the upper lid a little bit and I could spot a trabeculectomy bleb with 3 sutures. It is very important to elevate the lid and see the superior conjunctiva in anterior segment cases. Otherwise, you will miss findings like bleb, bandage contact lens, superior iridectomy and hyperleon. There was superior surgical iridectomy and PCIOL in this patient, so this is a case of status post triple surgery. The examiner asked, "Do you think it is a good bleb?" I hesitantly told that the height is not adequate. He asked, "So you think this patient needs a repeat trap?" I realized my mistake and I told, "No sir, the AC depth is normal and the cornea is clear, so it is a good bleb." He asked about the risk factors of failure, complication. He further asked about the causes of shallow AC, causes of deep AC with increased and decreased IOP. All these are beautifully given in Kansky, so I'm not repeating it here. Then he asked me about the management of bleb fibrosis. By then 6 minutes has lapsed and the second examiner stepped in. I examined the next patient who was woman around 20 years of age and found the patient to have posterior polar with blue dot cataract. I was trained only in small incision cataract surgeries, so I was really hoping not to get any cataract cases for the exam. He asked me about the management. I doubtfully told conventional phaco under guarded visual prognosis. How will you explain guarded visual prognosis? I will explain about the need of secondary IOL implantation. What secondary IOL? Iris flow or SFIOL? How will this surgery be different from other cataract surgeries? I told about hydrodelineation instead of hydrodissection. Clearly, he was expecting something else. So he repeated the question again. On seeing how clueless I am, he asked me what are the settings in phaco. I told I would do lens aspiration at 0 power. Thankfully, the bell rang and we were asked to wait outside for the next station. My next station was posterior segment. I was asked to examine the left eye fundus of an elderly patient in slit lamp with 90 diopter lens. The patient was rigorously moving his eyeball, even after repeatedly requesting him to fix onto the target. Luckily, I could spot a macular scar. Examiner asked me about the differential diagnosis. I told about CNVM, toxoplasma scar, and traumatic scar. Do you think it is CNVM scar? I told yes. What other findings will be there in CNVM? I told peripheral retinal changes like drusen can be there. Was it in this patient? I told I couldn't focus as the patient was moving the eye. So what could be the diagnosis? I told toxoplasma scare. Active or inactive? Inactive because there is no vitreous haze. Will you treat this patient? No, because it is not an active lesion. She also asked me about the treatment regimen. I elaborated on triple drug therapy. I was asked to examine the right eye of the next patient with indirect ophthalmoscope. I made the patient lie down. This was a young patient with vitreous haze, subretinal exudates, retinal edema, and venous sheathing. What could be this? Posterior uveitis. He asked the causes of posterior uveitis. I started with the obvious causes like tuberculosis, sarcoidosis, syphilis, and toxoplasmosis. He was not happy with the answer. He was expecting something else. He probed further. I told this could be of viral etiology. What virus? By this time, the examiner started losing his patience. I accidentally blurted out as porn. But thankfully, examiner was trying to prompt acute retinal necrosis as the answer. I was asked about the investigations. I told about the routine uveitis workup that we do in our hospital. He asked, what if everything comes out to be normal? What other important investigation is missing? After committing some miserably failed guessworks, I told about viral PCR. My next station was neuro-ophthalmology. I was asked to check the visual field. After grossly assessing the fields, I took out white and red targets. But the examiner discouraged me from using the target due to the time constraints. Hence, I completed the examination without targets, and it was left homonymous hemianopia. So the defect is in right optic tract. Other than the field restriction, what symptom will the patient have? The patient will have left side hemiplegia. Will the patient tell you that he is having hemiplegia? No, he will have difficulty in moving left hand and left leg. He asked about the management. While I was halfway through, the bell rang and the next examiner stepped in. For the next patient, I was asked to check the ocular motility. It was third nerve palsy. Now what else do you want to check? I said I want to check pupil, and it was pupil involving third nerve palsy. What will you do now? I will order CT with CTA and refer to neurosurgery department as it is a surgical third nerve palsy. If it is a 60-year-old diabetic patient, what will you do? I told if it is pupil involving, I will do the same line of management. If not, I will advise fogging or prism and do frequent follow-up. When will you operate on this patient? After 6 months. As there was still time left, examiner asked to examine the pupil of the next patient. I requested the assistant to switch off the lights and check the direct and consensual light reflex and did swinging flashlight test. The patient was having left eye RAPD. Before he could ask me any questions, bell rang and we were to move to the next station. Last station was Oculoplastics. My first patient in the station was having right eye dystopia. I was asked to do proptosis evaluation and comment on whatever I was doing. On inspection, the patient had apparent right eye inferior dystopia and lid retraction. On palpation, there was defective orbital rim. The examiner wanted me to quantify the proptosis with Hertel's ophthalmometer. A lot of postgraduate institutes may not be having this instrument. However, you can easily learn how to do the measurements by watching some YouTube tutorials. He asked what other things you should look for. I told about dry eye evaluation, lid signs, corneal sensation, and optic nerve functions. Then he asked about the differential diagnosis. By then, half time was over, so I had to move to the next patient. This was an elderly woman with left eye indropion with secondary trichiasis. Here also, I was asked to perform evaluation while explaining what I was doing. I had an inspection, palpatory tests like pinch test, snapback test, test of medial canthal tendon laxity and lateral canthal tendon laxity. The examiner asked about the management. I told lateral tarsal strip as there was horizontal tendon laxity. Examiner asked if I have missed any other finding. I inspected again and noticed conjunctival callosis. Examiner was expecting something else. Anyway, the bell rang before I could further look into it. So this was my experience with FRCS Ophthalmology Part 3 exam. I hope this video was helpful for you. Thank you.